Welcome to Cardio Tube. I'm Spencer King. I'm visiting today with Roxana Mehran, David Cohen, and Ajay Kirtane. We're going to talk about the best drug we ever had that we're going to throw away. That's called aspirin. I grew up with a pharmacology professor who told me there were only two drugs that worked, morphine and aspirin. He wasn't so sure about morphine. Now we're totally throwing it out, and the person who's most guilty, I guess, is Roxana Mehran, who was the principal investigator for the Twilight trial. Tell us what that was all about.
Well, first of all, thank you for having me, and I hope that we're not just going to throw away aspirin. I don't think that's the bottom line. I think what we need to do is to be more cautious, and that was sort of the premise behind the Twilight study, given the fact that there were a lot of things happening with understanding bleeding avoidance strategies and understanding the role aspirin plays on top of a potent antiplatelet regimen, on top of a potent P2Y12 inhibitor like ticagrelor. And we're seeing the signs, reading between the lines as far as the low dose aspirin being better than the high dose, etc. So we designed a double-blind placebo-controlled trial, and it was really on the heels. We were doing it at the same time, but on the heels of global leaders that was also looking at dropping aspirin with ticagrelor on board. And our idea was that we would only be able to accomplish this in a double-blind placebo-controlled fashion in over 7,000 patients. David Cohen served on the executive committee, helped us a lot. Thank you for all of your help. And the idea was, let's see what happens beyond 3 months of aspirin ticagrelor if we dropped aspirin and followed those patients for another year.
So what were we going for here?
We wanted to show that we could reduce bleeding.
Yeah.
Well, guess what? We did. That's not a rocket science there. But more importantly, I think we really populated the study with complex enough patients and lesions to be able to also have some power about the non-inferiority in the ischemic endpoints, the hard endpoints of death, MI, stent thrombosis, stroke, those parameters, and we achieved success.
So David, when was this a surprise at all? Certainly the bleeding reduction has been demonstrated before if you drop aspirin.
Right.
Was it a surprise that you could get along without it without any?
I think so. Because we just didn't know. Every single study up until very recently that's ever been done with P2Y12 inhibitors in coronary disease has been on top of aspirin. All of the pivotal trials that led to approval of ticagrelor, approval of prasugrel, were all on a background of aspirin. So there has always been sort of a nagging doubt. Now ticagrelor again has the advantage that it doesn't have any there's not a genetic polymorphism that leads to it being inactive. Both clopidogrel has a big issue with a wide range of bioavailability because of the way it's metabolized. Prasugrel has less, but still has bioavailability issues. And ticagrelor, being the active drug itself, doesn't have that issue. So probably if there's any drug that was going to provide ischemic protection without aspirin, it was going to be ticagrelor, where we don't worry about resistance.
So Ajay, what does a practitioner take away from this? Do they use ticagrelor? Because my information is that still clopidogrel is the main drug used across the United States in any case. How do we integrate this information to what people are doing?
Well, I think the points Dave made are really, really critical. So for practitioners, dropping aspirin always has made sense, especially late, beyond a year and that sort of thing. And people were somewhat reticent to do it, and now with data like this, they might feel better about doing it. But you have to recognize, first, is that these patients tolerated 3 months of dual antiplatelet therapy with a potent agent. And because of the resistance issues that David mentioned, I really would be reluctant to just say, go clopidogrel, drop aspirin, and feel free about it, and you're reducing bleeding, because the ischemic signal could be there, especially for those that are resistant. But I think that the big benefit of a study like this is it shows you that you can't just do a one-size-fits-all approach. You have to be thoughtful about how you treat your patients, and you may have options like this now, especially if you're treating with a potent P2Y12 inhibitor.
Yeah, I noticed that there remains a huge difference in the use of antiplatelet therapy across the country, even within institutions. Some argument about should it be different for acute patients, should it be different for stable patients, should you transition to a less expensive agent if you can. But this trial, although it's very impressive that it did this, I assume cannot be transferred to a practice where you're primarily using clopidogrel, because you don't know, for instance, whether the aspirin. I mean, if you're not responsive to clopidogrel, your aspirin's your only thing that's working, right?
Yeah.
And
Remember, STOP-DAP2 did do the clopidogrel-based strategy, but for U.S. physicians that don't do like 99% IVUS, which is what was done in that study, if you were to just translate that to your practice, I think you'd be really, there wouldn't be a lot of data to do that.
And I think also STOP-DAP2 was done in Asia. It was a Japanese study, and we, have learned
very
over the
low
years.
event rates.
Yeah, they clearly have some sort of different platelet biology, because there was the benefits of the more potent agents in Asia, whether it's just body size or whether it's other genetic factors that we don't fully understand, are different. So I think it's definitely getting out on the edge to extrapolate that far.
You make a great point, Ajay, about both of you do, about the excellent performance of the procedure. It's always been my opinion that laminar flow is a great antithrombotic. And so as people are doing more and more careful stent implantation, got better stents, use imaging sometimes to optimize that result, you end up with that many endpoints, right? So your trial with 7,000
our endpoint
was important.
Yeah, and we're going to be presenting some of that with IVUS guidance versus not. The majority of the cases were not IVUS guided, just so that everyone knows. These were complex patients and lesions in which the physician would decide to send the patient home on ticagrelor. We didn't assign that up front. It was the physician deciding to send the patient home on ticagrelor. So for the most part, we had 60% or so of acute coronary syndrome patients. And what I think one of the biggest things is that actually in acute coronary syndromes, we are now devoted to 12 months of DAP based on very old data from CURE, which was with the clopidogrel strategy. And now we have an idea with the ACS subpopulation showing exactly the same, so that you really could prolong that protection with a potent agent without the gastrotoxicity of aspirin. I think that, to me, is the biggest addition to what we have from the Twilight study.
Let me ask you one other question, which I'm not aware, I don't know about from Twilight. Some people have had side effects from ticagrelor.
Oh yeah, a lot of people.
So what happened to the people who wanted to stop?
Right, so we had all kinds of strategies, and it's just very tough to do this all in a small meeting like this, but certainly for sure, up front in the first 3 months, as Ajay said, we had open label aspirin and ticagrelor, and patients had to be compliant and event-free in order to get into the randomization aspect. So that's a really, really big part. Of the 9,000 patients, we ended up with 7,119. So there was 1,800 or so patients who got knocked out. Not all of them had events. A lot of them had shortness of breath. But our shortness of breath issues and issues with ticagrelor was actually less than what was observed in Plato, because we really had a great way of dealing with the shortness of breath. We used a lot of different strategies to deal with it, but we'll discuss that at another time. But it was a good thing.
Yeah. So my takeaway, and appreciate you visiting with us on CardioTube and helping us understand this trial. It clearly has demonstrated that bleeding can be ameliorated if you have a potent P2Y12 inhibitor to use, and at the same time, you don't give up anything in terms of thrombotic events occurring. I worry a little bit that people might inappropriately drop aspirin when they're using clopidogrel.
They should not.
Where we know that a certain number of those patients are not protected at all by the P2Y12, and the aspirin may be very helpful. Well, thank you so much for visiting with us on CardioTube.
Thank you.
Thanks for having us.